Welcome to October Grand Rounds 2020. Thank you for joining us. And today we have Dr. Amber Cunningham talking to us about POTS, getting to the heart of it. Dr. Cunningham is a graduate of Widener University's Institute for Physical Therapy Education with a Doctor of Physical Therapy. She's a board-certified specialist in pediatric physical therapy, and she also completed extensive pelvic health coursework and is now working on enhancing pediatric pelvic health services in the Miners and New Manhattan region. She has provided pediatric physical therapy in both medical and educational environments, and these settings include school systems, outpatient hospital-based clinics, inpatient rehabilitation, and acute and intensive care settings. Dr. Cunningham has focused on pediatric pelvic health and POTS, and she's committed to enhancing access to specialty pediatric therapy throughout Carbon County. So without further ado, I will turn it over to Dr. Cunningham.
Thank you, Dr. Kareha, and welcome to our October Grand Rounds. Today we're going to be talking about POTS, which stands for Postural Orthostatic Tachycardia Syndrome. I'd like to acknowledge Dr. Nanda for his help and mentorship and his commitment to patients across our network. This is our continuing medical education credit information, our designation statement, and I have no disclosures to disclose as it pertains to this presentation. Our learning objectives for this presentation are to understand the incidence and etiology of POTS, to understand criteria for medical diagnosis and management of the condition, to implement PT evaluation for guiding therapy progression and for individual goal establishments, to apply rehab guidelines to progress the treatment for clients with POTS, and to identify client resources for guiding patient support and maximizing participation. So 141 responded to a very non-scientific survey that Steve sent out last month about our department's experience with treating POTS. And of those 141 respondents, we found that 77.3 have heard of POTS. So most of us have heard of it. 21.3 have treated clients with POTS. And regarding expertise and experience, 73.6% say they're not competent in treating POTS, while 1.4 say that they're expert, and everyone else is somewhere in the middle. So that gives us a little bit of data on where we are as a department in understanding and being aware of this condition. So regarding how many Americans have POTS, an accurate estimate is difficult to conclude due to the fact that many people who have POTS go undiagnosed or misdiagnosed. It's also coded as one of multiple diagnosis codes, so it's very difficult to track. It's not a rare condition, but a rarely diagnosed condition. POTS is known to affect both men and women. However, it is more common in women, and men, when they do have it, tend to show faster recovery. Research has suggested as high as a 5-to-1 ratio of women to men who have the POTS diagnosis. It can affect people at any age, but it's much more common just after puberty and in women of childbearing age. And women are more likely to have relapses in their POTS during their pregnancy. Meanwhile, some estimates suggest that it affects 1 in every 100 teenagers. So that means a handful of teenagers in all of our high schools may have a diagnosis of POTS that they may or may not be aware of. All right, so this next picture might bring up some good memories for some people, some indifferent memories, and some bad memories, depending on where you stand. As far as I am concerned, the 2018 Super Bowl is one where I had a newborn in Delaware County, and I knew that if the noise and the celebration on Westchester Pike got any louder and woke up my baby, then Delaware County would see one angry mom. My other memory is, wow, that football player's baby with her pink noise canceling headphones is really adorable. However, a few months later, I did find out that Nick Foles' wife, Tori, who had their baby Lily, had been diagnosed with POTS in 2013. She never had symptoms before. She did not have symptoms as a teenager, but she woke up one day feeling dizzy. She was seen at a specialty clinic and spent a hospital stay to get a medical workup and treatment plan. And she has spoken about POTS at the Dysautonomia International Conference within the last few years. And she writes about her experience, her treatment, and her health on her blog. And that's where I learned some of this information from. So that is the Foles family. So what is POTS? POTS is a diagnosis under the umbrella term of dysautonomia. So this refers to a group of neurological disorders in which the autonomic nerve, or the ANS, has become dysregulated. It can involve the failure of either the sympathetic nervous system or the parasympathetic nervous system, or both. The symptoms of dysautonomia can affect every system in the body, and they may be mild or debilitating. The symptoms may vary in intensity over time and may come and go. Depending on the type of dysautonomia and its cause, patients may deal with symptoms permanently, or in some cases, they might recover. So here's a little bit of nervous system 101. So we have our somatic and our autonomic nervous systems. Our somatic is the control of voluntary skeletal muscle, while autonomic is our involuntary response to maintain homeostasis. So that balance between sympathetic and parasympathetic maintains our homeostasis. A little more nervous system 101, our sympathetic is our fight or flight response. So when we're being chased by a tiger, we have increased heart rate and decreased digestion. While in our parasympathetic system, which responds to rest or digest, we're going to see a decrease in heart rate and an increase in digestion. So our tools as clinicians are largely somatic in the therapy realm. Voluntary skeletal muscle contraction is our area of expertise. So why are we treating POTS as therapists? The somatic and the autonomic nervous system are so interdependent that in order to treat the autonomic side of things, we will talk today about the necessity of using the somatic system to help regulate the nervous system. So we're going to talk a little bit about, now we're into cardiology 101, and we're going to talk about what happens when you stand up. So a cascade of events occurs when we face gravity in a standing position. Normally, in a normal physiological response, we stand up and blood shifts from our chest to the lower abdomen, our buttocks, and the legs, from the vasculature into the interstitial space. That decrease in circulating blood volume is going to lead to compensatory physiological adjustments, and those include a decreased venous return, a decline in cardiac filling and arterial pressure, and a decrease in stroke volume. When those baroreceptors are unloaded, a compensatory sympathetic activation will increase heart rate and increase vascular tone. With time, venous return and cardiac output are restored, and usually within a pretty quick amount of time, we don't notice this reaction is happening. A normal response to standing is a 10 to 30 beat per minute increase in heart rate in adults and would be higher in healthy children. A negligible change in systolic blood pressure occurs, and about a 5 millimeter of mercury increase in diastolic blood pressure is seen in a normal response to standing. Now, what happens when people who have POTS stand up, especially after getting out of bed in the morning? So POTS is a condition of resting hypovolemia, which means there isn't enough blood volume to help support this cascade of events, and the autonomic nervous system is not supported in return. So basically, someone with POTS stands up, they have an inadequate compensation for the orthostatic decrease in blood volume. Their heart rate is elevated. That exaggerated orthostasis there's a shift in plasma volume. They see a decreased venous return that persists and doesn't catch up. Their cardiac output and their stroke volume don't entirely normalize, and their heart rate is going to remain elevated. So diagnosis. Depending on the severity of their symptoms and their sedentary or supine lifestyle, it can also be associated with a change in blood pressure, but it's not specifically POTS. Usually blood pressure is not affected, so it's not your typical orthostatic hypotension. To be diagnosed, patients would have non-cardiac or pre-syncopal symptoms for more than 6 months, and they rule out a cardiac etiology. There would be an absence of prolonged bed rest or deconditioning, dehydration, a medical event, a bleeding condition, or taking medications that would impair autonomic regulation. And there would be an absence of other chronic disorders such as dehydration, anemia, or hyperthyroidism. The gold standard for diagnosing POTS is a head-up tilt table test. In this test, they would use a tilt table, raising the patient to 70 or 80 degree angle. It's a passive test, so they're not weight bearing through their feet. Their muscles are not responding. They're laying down. And most importantly, to be diagnosed with POTS, you would see an increase in heart rate by 30 beats per minute with a tilt table test, or a standing test, which is an active test, having someone just stand up from lying down, with a heart rate of more than 40 beats per minute. Or with a tilt test, if there's an increase in more than 120 beats per minute within 10 minutes of standing and their symptoms are reproduced. So it's a pretty simple test. You can see here on this graph, somebody with POTS would have a heart rate in this picture of up to 170 beats per minute, and it kind of stays there, where their control might increase slightly and then drop off again in a decent amount of time. And other testing that patients who are being worked up for POTS might go through includes those tests that would rule out other conditions. So echocardiogram, a 24-hour urine collection, a 24-hour blood pressure and heart rate monitor, and blood work. Cardiologists and neurologists both diagnose POTS. There are autonomic tests that neurologists can perform that we won't get into today. So symptoms. It is important to remember that POTS is not a disease. It's a syndrome. And that's because it has a cluster of symptoms which patients may or may not experience. Dysregulation. It makes sense that POTS would affect various involuntary body functions and responses. So you can see from the list here, anything from nausea, headache, and dizziness would be the most common I've heard. And oftentimes you'll ask about GI dysfunction, sleep problems, and those might come up as well, but patients might not have associated them with their POTS previously. So this is a quote that I found. It's by a patient who has POTS. There's themighty.com has a bunch of patient experiences written on there. And this says, spinning around in a circle for 2 minutes, then trying to walk a straight line while reciting Shakespeare. So this quote is a great capture of that dizziness, that difficulty functioning mobility-wise, and that mental clouding that persists with people who have POTS. So when patients are prescribed exercise to help treat POTS, which we're going to get into in a little bit, they might look at the doctor like they're crazy because this is how they're feeling. They haven't been able to exercise for months, if not years. And when someone tells them that exercise is part of the treatment, go ahead and do this program, the thought of doing that seems impossible, because the thought of maybe even going to the mall and walking around with their friends is also impossible. So the gym might just be out of the question. And that's where we come in. And we'll talk about that more soon. So why? Why does POTS happen? Where does it come from? Now, the underlying causes of POTS vary, and most of the time with specific patients, it's not going to be known. It can be triggered by endocrine changes, including puberty and pregnancy, as well as triggered by viruses. Episodes tend to be triggered in patients with pre-existing POTS by those things as well. Now, research in POTS is very active. There's a lot of exploration in the dysautonomia world. Researchers are looking into various links to POTS, including their NET norepinephrine transporter protein, plasma blood volume testing, aldosterone, which tells the kidneys to hold on to more urine, which is low in patients with POTS, possibly explaining that hypovolemia. It could be contributing to low blood volume and driving the tachycardia. They're also looking into the role of antibodies in POTS. So when we look at what type of POTS there are, it's not so important to me, because in the literature, those type of POTS are interchangeable in some cases. People aren't right at using that terminology in an organized way. So I've read about 3 subtests of POTS: the hyperadrenergic, the hypovolemic, and the neuropathic. But I like to think about it as primary and secondary POTS. So if someone has Ehlers-Danlos syndrome, they're more likely to have POTS because of their ligamentous laxity. I know that the POTS is secondary. If there are no underlying factors, I know that POTS might be primary, but the treatment is going to be similar. So let's skip the page here. So why? The research just here in this study with my Grinch picture suggests that a small heart, which is more common in women, coupled with reduced blood volume, lead to decreased stroke volume and cardiac output and progression of POTS. So some research is looking into the idea that a small heart is a factor in contributing to POTS. In this study, they studied 25 participants and found decreased left ventricular mass, so their heart was smaller, and blood volume in those with POTS, and they found that autonomic function was intact. Exercise training increased left ventricular mass by 12% and blood volume by 7%, and it decreased their upright heart rate by 9 beats per minute. So exercise was very effective. It was a small group. I did find that almost all of the research regarding exercise, specifically in POTS, has very small n's. Now, 19 of the participants were no longer met POTS criteria after their exercise program and treatment, and all of the participants reported an increased quality of life. Those with EDS, however, so those with Ehlers-Danlos syndrome, were excluded from the study, so it might not be capturing the more difficult patients to treat. The study included exercise, which was 3 months long, and it was the Dallas protocol, which we'll talk more about in this presentation. And patients here reported the same compliance rate as compared to other drug and non-drug interventions in common diseases. So this is important to me. Some people might think exercise, you'd have less compliance, but I do find in these patients with the right guidance, and it looks like with the Dallas protocol and the follow-ups, they had the correct guidance, their compliance rate was just as good as taking medication. And in many cases, medications have adverse side effects in this population, so they're more willing to take exercise as a treatment in combination with their medical treatment. Now, why do we worry about POTS? Because it severely affects participation. In the pediatric population, you might see chronic absenteeism, lateness, kids hanging out in the nurse's office all day because they just don't feel good. Oftentimes, kids will be homeschooled due to these symptoms. They have difficulty sitting, focusing, and participating in school activities. And they may avoid social and sports activities because they just don't feel good. In the adult population, you'll see a decrease in employment, and approximately 25% of patients with POTS are disabled and unable to work. Almost all of the studies on POTS look at quality of life by the SF36, which is the 36-item short form survey, which is a self-reported health-related quality of life questionnaire. So it's a pretty general questionnaire. It's not standardized in the pediatric population, but it is important to talk about with POTS because they do use it a lot in the literature. All right, and in treatment. So treatment really looks at 3 approaches, and they're all in combination with each other to get the best outcomes. So behavior modification, we're going to talk about first, then medications, and finally exercise. Behavior modification. So physicians are really focusing on treating the reason behind the hypovolemia, and a great way to do that with most patients who have POTS is increasing their water intake, increasing their salt intake. Focusing on sleep. Sleep's really important. We know parasympathetically sleep is affected, and it's important to talk about good sleep behavior, good sleep patterns, but also to avoid sleeping too much. We don't want people resting too much that they're not getting enough upright tolerance. We talk about temperature control. We want these patients to avoid getting overheated. It's going to exacerbate their symptoms. Again, autonomic nervous system. We talk about compression if it's appropriate, whether that's lower extremity compression, abdominal binders. We talk about limiting caffeine. So their heart rate is elevated. We don't want it to be more elevated. And we talk about screen time and sleep. So again, with sleep, screen time is known to stimulate our nervous system. So we can't kind of switch over into that parasympathetic mode, and we don't get enough rest with increased screen time, especially important for patients with POTS. All right, so these are some of the common medications that you might see with your patients who have a diagnosis of POTS. They're usually on more than one medication because doctors are looking at controlling their symptoms through a variety of ways. So beta blockers can help control heart rate, usually low dose beta blockers. Acetylcholine esterase inhibitors, they may increase vagal tone to decrease heart rate. And HCN channel blockers also help to control heart rates. The next group of drugs are focused on increasing blood volume. So fludrocortisone is a synthetic steroid and it increases blood volume by retaining salt in the body. Other medications I haven't seen with patients I've had, but I have seen in the literature, include hormones. So desmopressin is a kidney hormone and it reduces urine production and promotes fluid retention. And that's a drug we might actually see in our pediatric population for bedwetting, but it's used in the adult POTS population to increase blood volume. However, it has to be very carefully monitored, which is why we might not have seen it with our patients. Another hormone is erythropoietin, which increases the production of red blood cells and subsequently increases blood volume. These cause blood vessels to narrow, which goes into our next group of vasoconstriction. So midodrine is an alpha-1 agonist. It's a vasopressor and antihypotensive, and it constricts veins and arteries. So it's all about increasing volume, increasing blood flow back to the heart, and decreasing our heart's heart rate. And finally, a final drug might include a centrally acting medication. And these work on the nervous system. I'm going to go back to this. So a lot of these drugs might have significant side effects. So patients might complain of diarrhea, abdominal pain, nausea, increased urinary urgency and frequency, increased mental clouding, which is very challenging in clients who already have brain fog, drowsiness, and fatigue. So many times some of these medications aren't well tolerated in some people. So physicians work really hard to find the right balance, and patients might not want to take them, depending on what the side effects are and if it outweighs the benefits of lowering their heart rate. So the third group of treatment, so we talked about behavior, we talked about medications, and now we're going to talk about exercise. So George et al. Studied 103 patients who completed a physician-directed program for 3 months. So they weren't coming into therapy. They followed a program that their doctor would follow up with them on. And they did it for 3 months. Now their heart rate upon a 10-minute stand was lowered after this 3-month protocol, and their quality of life measures improved. In this next study, which comes out of the Dallas research that started the Dallas protocol, they studied 19 patients with POTS and 15 controls. And here they gave them 4 weeks of a beta blocker or placebo, and then 3 months of exercise. Their training consisted of 2 to 4 week endurance, which started with recumbent biking, rowing, or swimming, and progressed in intensity toward upright posture. They initially started with weightlifting 1 time a week for 15 minutes, and then 2 times a week for 30 to 40. So in the end of the 3-month period, they were exercising for 5 to 6 hours a week. As well as exercise, everyone was prescribed salt and water. So salt and water definitely improve symptoms in most of these patients with POTS, as long as they're not hypertensive. And everyone got that in this group. So what they found was that both groups lowered their heart rates. Their standing cardiac output decreased after the beta blocker, but minimally changed after training. Their aldosterone-renin ratio increased after training, and patients' quality of life improved after training, but not after the beta blocker. And they use the SF-36, so the short form health survey, to assess their quality of life. They suggest that for patients with POTS, exercise training is superior to propranolol, the beta blocker they used, at restoring upright hemodynamics, normalizing renal adrenal responsiveness, and improving quality of life. The study shows that deconditioning plays a large role in symptom production and that aerobic exercise will increase vagal tone and control heart rate, while muscle training of legs will help with the venous return. And then one final study here on long-term outcomes of children and adolescents with POTS after conventional treatment did look at 120 participants. They looked at their duration of symptoms before treatment, and max heart rate and standing were indicators of long-term outcomes. Treatment included education on diagnosis and management, water, salt, and orthostatic training. Now, this training did not include a strengthening program. There was no endurance program. It was basically an incremental increase in standing while leaning with their back against a wall. And they did find that 48.4% were symptom-free at 1 year, and 85.6% were symptom-free at 6-year follow-up. And my hypothesis would be that with a more progressive activity protocol and exercise training, that more of these patients would have been better sooner, but it would be nice to have a larger study, longer and more progressive treatment outcome. So what is the Dallas protocol? This protocol came from research from the Institute of Exercise and Environmental Medicine, Texas Presbyterian Hospital, Dallas, and the University of Texas Southwestern Medical Center at Dallas. So that's why it's called the Dallas protocol. It's an 8-month training calendar. It includes endurance days and strengthening days. Months 1 through 4 are usually only exercise in a horizontal position. So patients are laying down on the floor potentially, or they're in a recumbent reclined position on a bike, a rower, or swimming with a kickboard. Month 4 progresses toward upright bikes, and months 5 through 8 progresses toward elliptical and treadmill. And these days are alternated with strength training, which is usually completed in the position that they are also doing their endurance training in at the time. So it's progressive. Patients can start anywhere on the protocol depending on their symptoms. Typically, I always start everyone reclined, and very commonly I start them in a supine position because they are symptomatic in a reclined position, and we want to avoid symptoms when we do this protocol. Now, what does an examination look like? So we want to take a very thorough history. When did symptoms start? There is evidence to suggest that the longer patients have symptoms, the more difficult it is for their symptoms to go away, as well as the higher their heart rate is in standing, the more challenging it is to control their symptoms. So when were they diagnosed? And there is a push for earlier diagnosis, which I've actually seen in the last couple years, which is very promising. What's their social history? Are they participating in sports? Do they want to participate in sports? Are they attending school? Are they making it to work on time every day? Their patient report of symptoms, positions, daytime changes, etc. All this is really important in getting a good picture of what their personal goals might be. Now, getting flexibility in check is important. Assessing their strength. If they're deconditioned and they haven't been active for a year and a half, it's most likely that they're having some strength challenges that need to be worked on. And we know that strength increases venous return. So we want to get a good picture of where they are at the beginning. We want to assess pain, their gait, their mobility, their posture, and get a good thorough examination of the response to position changes. Check their heart rate and their blood pressure in laying down, seated, and standing positions. Now, exercise testing isn't something that we talk too much about in the initial trainings here at St. Luke's, but there is a push for more regular exercise testing. So theoretically, testing should be done at their initial eval if possible, and then every 1 to 2 months to track their exercise capacity. So in the literature, the testing that's been used that I've come across is the Astron-Rhyming cycle ergometer, and this is something we can do in almost all of our clinics. There is a thorough testing procedure that I can send to you if you need it later. And in the later stages of treatment, Bruce treadmill protocol, because they might be tolerating upright positioning well, but it's when they get to prolonged activity that they're struggling in upright. In our assessments of patients, especially ones who have POTS, we really want to look at their Beighton score. So we want to look and see how hypermobile are they, and is this impacting their posture? Now, I could go into a whole presentation on EDS, and we won't do that today. We can save that for another time. But Ehlers-Danlos syndrome does have a higher correlation in people who have POTS, and it's important to recognize the signs and symptoms and their history and get a good number on here. So a 5 out of 9 or greater indicates hypermobility. And if you're coming across someone who has significant hypermobility, you may want to refer them to a connective tissue physician for further workup just to help manage those symptoms as well. So quality of life. I like to stick with what is being used in the literature so we can compare it in the future. There isn't anything great in the pediatric population for quality of life and POTS. We'll have to look more into that. But the autonomic symptom profile is a validated self-report questionnaire that looks at autonomic symptoms across 11 subscales, and it yields a composite autonomic symptom score. So it is long to administer, but it's a great way to get patients thinking about other symptoms that they might not have associated with their POTS that are falling under that dysautonomia umbrella. All right, so treatment, strengthening, so important. We know it increases muscular tone, it increases vascular return. It's about 20 to 30 minutes, 2 to 3 days per week, and you can work up to that. Usually alternating endurance and strength days is the best way to work through the protocol. And again, you want to meet them where they are in the protocol. So if they're only tolerating supine positioning for their endurance, you really want to strengthen them only in a supine position. Consider their home equipment, what resources they have, if they have access to gym equipment, and gear their program toward what they have access to make it most successful. All right, so when giving someone an exercise program, especially someone with POTS, we really want to consider their sports history, their interests, their symptoms and heart rate, their compliance with an exercise program. So have they done this Dallas protocol before and they never got through to week 3? Do we really want to give them a program and send them on their way again, or do we want to work more closely with them and figure out what's hindering their compliance? And then family support and resources are going to be the most important too. So a few exercise extras. Again, we talked about compression stockings for increasing venous return, but also if patients are having a lot of morning symptoms, sleeping with their head of bed elevated or using wedges is a great resource just to help it so they can be a little bit more functional in the morning. Having them learn to take their heart rate manually or to use a Fitbit or a heart rate monitor. Getting them set up with a reclined bike or pedal in their community or home is really important, so that way they can increase that carryover and they'll be able to do their endurance protocol at least 3 times a week. Making sure they have a water bottle throughout their session. So water is so important. Salty snacks are important, and we want to make sure we're following their physician's guidance and making sure they're getting their 2 to 3 liters a day, and especially around their exercise times. It's important to give them an illustration of their RPE scale, especially if they're on beta blockers, because they're really going to have a hard time maintaining a good sense of what their heart rate is or should be without knowing what their RPE is. And we want to avoid exercise in the heat. So here's a nice picture that I love to use. I have this laminated in a few different varieties in our clinic for patients to look at, so they can get a good visual sense. I think this is great for kids, but it's great for adults too, of how hard that they are working. All right, so what are our goals? Our goals for treatment are independence with their protocol, number 1, that they'll have an improved autonomic symptom report, that they will be independent with their lifestyle modification. So if they're doing their exercise, but they're really not getting their water intake, they're really not getting their salt in, they're not going to feel as good with exercise alone. All the research showed that the exercise programs that were completed in conjunction with water and salt at minimum. And then finally, that they'll demonstrate improved exercise capacity testing by, I would suggest 10% as a short-term goal and 20% as a long-term goal. Now follow-up. So this is definitely patient-specific. Some patients could be seen for 1 or 2 sessions and sent on their way. Others might be seen 1 to 3 times a week. It really depends on their severity and what resources they have. Now consider advancement toward monthly or consultative level of care, especially to get them through that 8-month protocol. They might have relapses. They might get sick and have a virus and be set back a month. And it's okay to start the protocol in another spot. The importance is that they keep on working toward it and that they're working without symptoms. All right, so we're just going to go through two cases here. I picked one for an adult patient and one for a pediatric patient. So this was a 22-year-old female that I saw. She had started passing out about 6 months prior to our visit, especially after taking a shower or during a shower. So you can imagine that the safety implications here are major. Showering is a huge spot that people who are passing out with POTS, they are more likely to have more symptoms during or after a shower. So you imagine they're standing for a long time, they're not moving, so they're not getting that venous return from their muscles pumping, and it's hot in the shower. So put all that together and they're more likely to have an episode. So this patient was admitted to the hospital for 4 days for medical workup. She was ultimately diagnosed with POTS 3 months later, but she did remember having chest pains 2 years prior to this event. And she was told it was anxiety. So you'll find that most people who have POTS also might have a diagnosis of anxiety or were told that they're anxious, although the research does suggest that people with POTS are no more likely to be anxious or depressed than the general population. However, from an interdisciplinary standpoint, it is important that these patients also work with psychiatry because the diagnosis can play a big role in decreasing their quality of life, and it's something that they might have to work through with professionals outside of our scope of practice. So back to this patient. She was prescribed a beta blocker. She actually never took it. She wanted to try water and salt first. So at her PT evaluation, and her doctor was aware of that before she even came to PT, that she didn't want to take the beta blocker. So at her PT evaluation, she had a 2 out of 9 on the Beighton. So she was kind of like a little hypermobile, but no generalized hypermobility. She did have generalized body weakness. I would point her in the direction of being low tone as far as her muscle tone was involved. At her PT evaluation, her blood pressure was 115/70 upon standing. Her heart rate was 79 laying down, 95 in sitting, and 105 in standing. So not too crazy. But her tilt test that she had had prior revealed that her heart rate was 75 to 121 upon standing, and her Holter test showed a syncopal event, at which point her heart rate went up to 160. Her PT course included starting her on month 1, day 1 of the Dallas protocol, and she started this in supine, laying on the floor with her feet on the bike pedals. And this is because trying her on a recumbent bike increased her headache and dizziness, so she wasn't ready for that position yet. She completed 12 PT visits at 1 to 2 times a week, and her exercises included completing endurance days, strength sessions in PT and at home. Her exercises were basically very of TA stabilization, progression of planks, bridges, straight leg raises. Typically, as PTs, we're not big fans of open chain exercises, but in the supine stage of this protocol, it is very beneficial to work on these open chain exercises and focus on core stability. So at 12 visits, she reported improved dizziness, improved headache, improved exercise tolerance, and improved energy overall. She continued with persistent leg pain though, and she was seeing neurology for that as well and getting a venous study at the time. Now she was moving out of state and she was discharged to the protocol alone. She didn't require further PT at this time, but she was, if her symptoms increased or if any changes happened, to ask for a PT evaluation to see kind of where she is. Now, most importantly for her, and what she was the most excited about, is she hadn't passed out in over a month. So that really changed a lot. It made her less afraid of taking a shower. At the time, she had to have her roommate around when she took a shower because she was worried she might pass out. And she was a month free of passing out. So hopefully she's still doing well today. All right. In case, someone I presented on previously, she is a little bit more complicated in that she has mitochondrial myopathy, acquired hypothyroidism, asthma, depression, anxiety. She's G-tube, uses a G-tube for supplemental nutrition, has reflux, she has hypoglycemia, and she uses a Dexcom for continuous glucose monitoring. And she came to me after failing PT previously. So she would tell her PT, I'm dizzy, but she was pushed on the treadmill regardless. And I'm not sure, but it sounds like she was not progressed along a positioned protocol. She was just started with exercise and treadmill walking, which ultimately increased her symptoms. One of her biggest complaints was that she couldn't walk up the hill after school. She had a hard time between classes, especially standing up after 45-minute classes, and she would get nosebleeds when she got out of bed too early in the morning. So mom actually was able to get a hospital bed from a friend that had she could elevate the head of the bed, and that made a big difference for her. And she did that also while she was completing PT. She was working along the protocol. And more importantly, she was exercising without feeling dizzy. So she was able to join her spirit team the next year. When she came in, and she said she got off the bus and went home and did not have any dizziness. She didn't have to lay down when she got home. That was a big one for me. I wasn't doing a lot of quality of life assessments at the time, and I wasn't doing exercise capacity testing. So I'm curious to see that as we increase this testing, what our next case studies and results might look like. So what does it look like? Now, there's no definitive cure for POTS. There is a lack of good long-term follow-up studies across all groups of people who have POTS, and outcomes are improved by treating the underlying cause, if able, and lifestyle adjustments. So the dysautonomiainternational.org website is quoted as, "The prognosis is good for most patients. Researchers have noted that some patients will not improve and may actually worsen over time." So it's a little bit wishy-washy in terms of what prognosis might really look like, but here's a few of the results that we do have. Now, I think patient support is the most important. So number one, referring them to a counselor is very helpful, but also getting them connected with other people who have POTS. They might think that it's so rare, they don't know anyone else who has it, but showing them some of these resource groups, they might meet other adults or other children who have the same diagnosis and might have tips or tricks or just comfort in knowing that they're not alone. Now, October is Dysautonomia Awareness Month, so it's fitting that we're doing this presentation in October. And finally, we're just going to review what we went over today. So the prevalence and etiology of POTS is largely unknown, but we know a lot of people have it. So it's important to be aware of it. POTS can cause a lack of participation and disability, and a multifaceted approach is shown to improve quality of life in people who have POTS. So this is not something we treat alone. It's really important, especially with medications, that we're working with the doctor to know when they're supposed to take their medications, especially around exercise, how much water they're drinking, if they're allowed to be given salt and how much they should be having a day, and keeping a close relationship with those prescribing doctors so you can best meet the patient's needs. Now, as a large hospital network at St. Luke's with well over 50 offices, we're seeing clients across the lifespan for a vast variety of impairments and functional limitations. Because POTS is recognized as an autonomic nervous system dysfunction, its symptoms are going to span from difficulty walking, chronic fatigue, muscle weakness, deconditioning, even vestibular dysfunction, migraines, and mental clouding. Now, I hope that this presentation helps you all better recognize the symptoms of POTS, know when to refer, and what diagnostic workup might look like, and then to help treat the client with POTS, or to help treat the client with a scientifically researched and proven exercise and lifestyle program. Not one client who has POTS is going to look the same, and there's no better clinicians to be a part of a POTS treatment plan than you. Thank you for joining me. Here are some references, and you're welcome to email me if you have any other questions or recommendations about this presentation or questions about POTS.